So it's my great pleasure to introduce our next speaker, Dr. Robert Rhee, who's going to discuss direct carotid access for stroke prevention and management for intracranial and cervical intracranial vascular interventions. Dr. Rhee really needs no introduction, who has been a colleague of mine for a number of years. He's an international leader in the treatment of complex carotid diseases. He has extensive experience in both direct surgical and vascular management of complex abdominal, thoracic, and thoracoabdominal aortic dissections and aneurysms. He has been involved with and has led many significant vascular device trials since 1995 and continues to bring state-of-the-art technology to residents of Brooklyn and New York City by offering the latest minimally invasive treatment options not generally available to some other most local hospitals. This includes fenestrated and branched graft aortic endovascular repair. He's director of Maimonides Medical Center's Aortic Center, has published over 100 articles in leading journals and textbooks on the topic of vascular diseases. He has lectured in over a dozen countries worldwide while serving on and leading various national committees in the Society of Vascular Surgery, Eastern Vascular Surgery, and also Society for Clinical Vascular Surgery. He served as both the institutional and national lead investigator of several clinical research trials. He's currently the president of the Eastern Vascular Society. So let's welcome Dr. Robert Rhee. Bob.
All right. Good morning. Is everybody awake after the coffee? It's a pleasure to be here. Once a year, I come to this conference and I learn quite a bit about all the latest stroke management protocols. And I especially enjoyed the lecture of the summary of the recent stroke meeting because it's just sort of a quick update for us. As vascular surgeons, we work very closely with the stroke team here. In fact, we're an integral part of the stroke team, which is not all that prevalent, unfortunately, in the country. About 10 years, a little over 10 years ago, I came here to direct the vascular unit, but the place that I was at before was the University of Pittsburgh, and there was no collaboration between vascular surgery, cardiac surgery, or the stroke service. The stroke service basically did whatever they wanted. They didn't really take into consideration any other aspects of the multidisciplinary process. And it was not good for the patients. And the results really, at that institution, they really didn't really care about the results. They just wanted to do the most up-to-date procedures and see how many procedures that they can do for these stroke patients, and we saw a lot of complications. And one of the major complications was that the stroke service, which was led by a stroke neurologist, interventional neurologist, would just routinely puncture the common carotid artery. Without ultrasonography, he would feel it, puncture it, and then ask vascular to come and fix it at the end. But of course, there were a lot of complications. There's a lot of plaque, there's a lot of disease there, there's all kinds of things that could occur when you blindly stick the carotid artery. Now, someday, and I've talked to several companies about this, there will be a time when a safe percutaneous closure device will be available for the carotid system, but none of the companies that I've talked to really want to take on that risk. There's all kinds of closure devices, but currently the closure devices are really not indicated for a direct carotid stick. So I appreciate the collaboration here, and I think it's really the end result is that the outcome for the patients are significantly better here than I've seen at University of Pittsburgh. These are my disclosures. So my agenda is basically I'm going to go through four things. Direct carotid access technical tips, which is not very technical. You just cut down on the carotid and access it, but just so that everybody's clear, there are different ways to do it. But generally, the protocol is that if the stroke team gets an acute stroke patient and they see a hostile arch or some other contraindication for transfemoral access, they call us, and we kind of are available to do the case with them for the direct carotid access in the safest way possible. And in 2024, that's a direct carotid cut down. Femoral access limitations, we've all seen this, and I'll go over some of the limitations that we've seen over the years, and role in ischemic stroke and role in stroke prevention. Okay, so the bottom line is, how much more difficult is it to access the carotid system doing a transfemoral remote approach versus a direct carotid access? Well, everybody knows if you have a pair of chopsticks or a long tongue, the longer it is, the more difficult it is to control. And all the interventionalists here knows exactly what I'm talking about. The further away you're from the target, the more difficult it is to deliver devices as well as to manipulate the wire through the lesion. So it just becomes, what's better, long or short? Of course, short is going to be better, but that's not necessarily the right thing to do in most cases. So a carotid access typically involves an incision. These are the landmarks. I'm not going to go into the details of it, but it's a relatively straightforward procedure for us. We just cut down on the carotid artery, and we find a relatively disease-free spot, and that's where the stroke team gains access for much more control at the level of the brain, because it's less than a foot away. So the torqueability of the wires and the devices becomes much more maneuverable. And because you have the carotid access right at that point, you're only inches away from the intervention site. And and as vascular surgeons and interventionalists, we know that, you know, if the lesion is very close, it's much easier to go through the lesion, treat the lesion, and do all the other adjunctive procedures related to the lesion. This is from the literature, but this is one of the first, one of the reports of how direct carotid access will allow the stroke interventionalist to treat more complicated and extensive lesions than the typical transfemoral or transradial approach. And this was this is sort of the typical layout. Again, it looks a lot more complicated than it is, but you can see that the neck is right here, and because currently all the interventional devices are relatively long, because you're coming from the radial approach or the transfemoral approach. It's going to be a little bit cumbersome, but sooner or later, as soon as some company develops a percutaneous access device for the carotid system, all the companies should shorten their devices for direct access. And eventually, maybe this will be the way to go. And as you know, femoral and radial access for the intracranial circulation is just simply difficult because of the length. In short, it's just very difficult to manipulate the devices, although everybody in this room is very skillful at it, but it just takes a little bit longer. Transfemoral approaches is less dangerous because you don't have the possible access complications of a carotid system. Like I said, when I was in Pittsburgh, the stroke service, the neuro radiologists just used to just puncture the carotid routinely, and they would just call us after the fact, and there were multiple strokes as a result of direct punctures and lifting of the plaques. The common carotid artery is never without disease when you have severe bifurcation disease. There are complications from transfemoral access, such as retroperitoneal hematomas, et cetera, but neck hematomas can be fairly deadly with respiratory compromise if not picked up early. So that's clearly an area that needs improvement if we're going to work on a percutaneous system. The femoral access limitations is primarily related to the arch. And And really, everybody here knows the literature on carotid stenting, carotid endarterectomy, et cetera. And we all know that during the NASA trial, and particularly during the ACAS trial, at least 50% of the strokes occurred during angiography, traversing the hostile arch, not during the actual carotid stenting or the endarterectomy. So going through a hostile arch when it's beautiful like this schematic shows, is not a problem. No matter what type of arch it is, even a type 3 arch, if it's disease-free, it's not a problem. But you're not going to get this. You have all kinds of stuff in here which contributes. So direct carotid access becomes attractive simply because of that reason. And logistically, just going from a transradial or transfemoral approach, you're taking many more hairpin turns to get to the access sites, again, limiting your maneuverability. And another area that's useful for direct carotid access is when you have severe tortuosity of the internal. So you go through the arch, you're winding around through hairpin turns, and then you encounter a lesion here, and sometimes you have tortuosity here. So every turn creates a little bit of a burden on the torqueability of these devices. And this is just a paper that was written showing exactly the variations in the hostile environment. So this is a typical common carotid artery for neurointervention. And as you can see, it's not disease-free. So percutaneous access, really needs to be approached carefully and with ultrasound guidance when it eventually becomes a reality. So stroke treatment. Now, I'm not, I don't know a lot about this. I just, read about it, and this is the literature on it. But there's been multiple reports, a flurry of literature within the last 5 to 10 years describing direct carotid access punctures and how much benefit that a patient can get by having such closeness to the intervention site. And this is a paper showing a thrombectomy. There's multiple papers out there. This is just the tortuosity. You can see the arch. You don't want to be going through a very calcified aortic arch and manipulating 6, 7 French sheets through this. But every time you scrape it, I just recently did an angiogram on a patient with a cumeral diverticulum, which is an abnormal aneurysm off the arch, and the patient had disease, so I wanted to see the exact anatomy a couple of weeks ago, and I did just a simple angiogram with a pigtail catheter in the arch, and the patient had a stroke afterwards. And that just goes to show I did not manipulate, I didn't catheterize any of the arch vessels, but because the patient had significant disease right around the entry of the arch vessels, luckily the patient recovered and we'll be able to fix that. But just putting a catheter into the ascending aorta and doing a power injection is a stroke risk, as you all know very well. This is pushability. That besides the torqueability, there's also the pushability concept. If you have a carotid occlusion, it's much easier to go through the carotid occlusion. There was a neuroradiologist, I don't know if he's a neuroradiologist, but the guy name was Tudor Jovan, and he went through, no matter how occluded it was, he would just shove devices through these occlusions 100% of the time. If it was a carotid patient comes in with a massive stroke, he would just push a wire through it, and his access of choice was to access the common carotid artery because of the pushability. And I'm not, our group here is not that aggressive, and it's a much more of a database-driven stroke service versus the Pittsburgh group. But this group, this concept of pushability is a real concept for direct carotid access, because it is very difficult to get through a chronically stenotic or an occluded lesion when you have a transradial or transfemoral approach. Intracranial tortuosity is also an area that can be best served with, if if it is difficult, and there's no sin to trying a transfemoral approach. If there's too much tortuosity, you can always, get carotid approaches as well. But the tortuosity is clearly something that everybody needs to contend with, and both in the intracranial as well as the carotid circulation. So this is really the nuts and bolts of the whole talk, really, is that the puncture to intervention time for transcarotid intervention is significantly lower across most studies, meaning the moment when the patient comes into the stroke center to the point where the actual intervention is performed, whether it's suction thrombectomy or stenting or whatever it is, most studies show that it is significantly lower for direct carotid puncture. And this is a study from 2020 by Cord and Quadali. And this group is a relatively well-known group. I believe they're neurosurgical interventionalists. And they describe the direct puncture about and describe how you can get through these, not just the tortuous anatomy, but basically these loops, because if you have much more direct pushability. And again, I keep emphasizing these, and those are the two concepts: is the pushability and the tortuosity, torquing ability. So another area is to be able to control the access point for TPA, for direct infusion of TPA. I don't think you guys use much direct infusion of TPA anymore, but I mean, this is a paper from 2020, but there's been several reports of doing a cut down, and this is a cut down, not a direct puncture. But it was, like I said, it was very refreshing to, work with a group. And this is one of the beauties of being in a tertiary care hospital that's nimble, because, the egos are put aside. Everybody is collaborative. The neurosurgeons, the vascular surgeons, the stroke neurologists all kind of work together to get the best outcome. And I'm not going to skip over that. So basically, this is the procedure for a carotid, and you can see it's a very small incision. We can do it in the interventional suite, and once the carotid access is performed, we just come back and just basically purse string closure, the closure and the skin. So for us, it's a relatively simple procedure. We're always available to help. There's 4 vascular surgeons here, so we work very closely with the stroke service regarding that. This is another paper showing that direct common carotid puncture for endovascular treatment for large vessel ischemic stroke in a patient with an aortic coarctation. So this patient, they couldn't even get through the aortic coarctation, so a direct carotid puncture was performed, showing excellent results again. And this is a patient with a variant of the arch. And again, if you have a very abnormal arch, sometimes you have a bovine arch and you have a lot of disease and you don't want to risk embolization to the contralateral side, that's another indication for a direct carotid puncture. And this is the final result. And again, you're only inches away from the intervention site. So the one-to-one torqueability is extremely good at this level. So the final thing that I'm going to talk about is stroke prevention. And I'm sort of rushing through this, but the only thing that really kind of came out of everybody thinking about common carotid access was that really you need to do a cut down at this point, because we don't have the devices to do a safe percutaneous closure. We have large hole closure devices, but the leading point is just too cumbersome to use in the carotid system, because that leading point could be going through the carotid bifurcation. So that's really prohibitively dangerous, especially in a patient with carotid bifurcation disease. So carotid revascularization has been done in the past before this transcarotid TCAR concept came into being. So TCAR means transcervical carotid artery revascularization. And basically, it took that basic concept of a cut down, and a company developed a sheath to directly access the carotid system. And this has been a fairly significant advance because of the fact that not only did the system allow you to have a sheath and a procedural cut down protocol, but it also allowed introduction of a very large sheath to create a flow reversal. So we've had a fairly extensive experience with TCARs here, and we've been doing it for the last 3 or 4 years, maybe even longer, can't remember. But the TCAR results mirror what's reflected in the literature from the ACAS study, the NASA study, the CREST study, namely that traversing the arch can be a hostile situation. And if you look at the data for transfemoral carotid stenting, the results show that the combined stroke and MI rate is about 4% or so. And that percentage point is significantly reduced if you just directly access the common carotid artery, as in the TCAR system. And that's evidenced by multiple studies which showing that the stroke rate, is now, the reason why, CREST has really kind of dampened the enthusiasm for transfemoral carotid stenting is that the stroke risk for transfemoral stenting of the carotid, internal carotid bifurcation has been significantly higher than carotid endarterectomy by 2-fold. So what appears to have happened is that using transcervical, that difference has dissipated, meaning carotid stenting now is pretty equivalent to carotid endarterectomy when you do a transcervical approach. So, there isn't much literature in the neurology literature regarding direct comparisons of transfemoral versus direct carotid punctures for neural interventions. I mean, I don't think there's any side-by-side studies that I saw, but clearly, there's been multiple studies looking at TCAR and carotid endarterectomy. And the reversal of flow allows us to retrieve the blood through a filter. And this is the kind of stuff that you see during a carotid stenting procedure. And it's not minor. And those of you who've done, when carotid stenting became available, I don't know, 15, 20 years ago, I at one point at UPMC, I did probably about 50 to 70 a year personally. The neurosurgeons were doing them, the cardiologists were doing them, the vascular surgeons were doing them. And at that point, the stroke risk for a patient who comes in with an acute neurologic presentation was fairly high. I mean, I recall many instances where we did carotid stenting and the patient would just go out or have a TIA right on the table. And it's because of this mostly. And the filters were not 100% efficient. So this procedure basically, and primarily the company devised this special sheath called enroute sheath, which kind of sits in the carotid and can't be pushed in and allowed to cause damage in the common carotid system, so you can do an intervention. And this TCAR procedure is probably one of the easiest vascular procedures we could possibly do. It takes like 30 minutes. It's so easy to do this compared to a transfemoral carotid stenting procedure, and the results have been excellent. And you can do retrograde as well. That's another indication for a common carotid access point, is that instead of pointing the sheath upward, you can point it downward and create flow reversal and do a retrograde innominate artery stenting for symptomatic disease. like in this particular case. And again, it's relatively easy because you're right here. So you're literally 3 inches away from the innominate, and you can flush out the carotid, and it's a relatively, it turned a very risky procedure into a relatively safe procedure. And this is a Vascular Society database analysis of carotid endarterectomies and transcervical carotid interventions with TCAR. And again, this is hundreds of patients. And as you can see, these are the asymptomatic patients, symptomatic patients. As you can see that there's no statistical difference in the stroke rate between carotid endarterectomy and TCAR. This is the first time that, in a prospective study that carotid stenting was shown to be equivalent. And it is going to be equivalent if you take into consideration all the hazards and all the dangers of the arch. So I know I ran through that very quickly, but I wanted to leave some time for questions and see what people's thoughts are on this. But direct carotid access should always be part of a stroke center's armamentarium. It's not a difficult procedure for us, and it allows the stroke service to gain direct access. And unfortunately, most centers, you don't have that collaborative effort between vascular and the stroke neurologists. It allows for a safer and more effective, as demonstrated by the TCAR approach, intervention with hostile arches and extremities, or access points, radial artery or femorals. Much closer distance to the intervention point allows higher degree of control. Multiple studies have shown that TCAR is as safe as carotid endarterectomy. And, the CMS has just approved transfemoral carotid stenting for reimbursement just within the last few months. And, we'll see what the real life results are. But, the world has a huge experience with transfemoral carotid stenting, and we know the results. And the results are excellent, except for the arch part of the procedure. And, and it's really nice to be able to work in a collaborative environment. And, we are always here to, we have a vascular resident and fellow always on call. So if there's any stroke service problems, we're more than happy to help out. Thank you.
Thank you, Rob.
Yeah, question.
Fantastic. It's great talk, overview for the different access and, short period. I couldn't echo more of what you said, this collaborative, interaction between us and vascular surgery and, CT surgery, cardiology, and all the services we interact with. It's truly an amazing relationship. Truly appreciate that. Any questions for Dr. Rhee in the audience or online? Oh, yes, Dr. Patel from MGH.
So when you do the closure, have you tried any of the closure devices? Like, not for TCAR, obviously, which is a different unique system, but if you do direct access for stroke, I know a lot of people have talked about doing, a cutaneous puncture and then closing.
Yeah, I have tried closure devices. I've tried ProGlide. In a situation where I did it a couple of times in Pittsburgh, where there was a percutaneous access, and there, I think one of the residents deployed a ProGlide, and because I thought it was so femoral artery, carotid artery, same thing, but it actually worked. But if you have a bifurcation lesion, it's going to be very difficult. And I've also used the Abbott Star Close. You just have to make a track. But again, none of these devices are indicated. And if it fails, you can have either thrombosis or an intravascular component of a closure device. And I don't think we want that floating down downstream into the brain. So, I think it's limited by the fact that there's no real good closure device available currently. But eventually somebody will come up with it. But, I've talked to several companies about this a while back, and very few companies are willing to take that risk. I mean, probably Abbott gets calls, hundreds of calls a week regarding their closure devices, how this didn't work at the femoral level, okay? So I don't think a company wants to take that risk. If the closure device doesn't work in the carotid, you're going to thrombose the carotid, and that's not a good situation. If thrombose the femoral artery, we can fix that easily, but a thrombose carotid system all the way up, not so much.
I mean, Charles Matuk, has done a bunch of direct puncture strokes at Yale, says that the biggest complication is access site complication.
Oh, yeah.
When we do it at MGH, I usually do a direct stick, but then after the revascularization is done, I'll do a cut down and then
Right.
surgeon. So it's easy that I just open it and close it. But we found that it's faster to do the direct stick, so you can keep moving to do the revascularization.
No, yeah,
And then take the time to do the closure at the end after you've achieved.
yeah, there's nothing wrong with that as long as the direct stick is meticulous and guided by ultrasonography, so that you don't stick into the, in the calcified segment of the common carotid artery. And I've seen that where you can actually, raise plaques at the
Times you've already done a femoral puncture, so I just do a road
you have a
map.
pic, yeah.
You can use a road
Yeah.
map and then you can.
What do you use do you just have the vascular service just close it after the fact, right?
Well, I close it myself.
You close it yourself, okay.
But but our partner.
Neurosurgeons would do that, but not very few
A neurosurgeon.
Okay,
So,
okay, that's what I thought.
But members of our team that are radiologists or neurologists would either call one of me or the other neurosurgeon who's an interventionalist if it's during the day. But if it's on a weekend, they typically will call vascular surgery
Yeah.
to do it.
Yeah, I think when I was in Pittsburgh, the neurosurgeons did a lot of the percutaneous, direct carotid punctures, and we never heard from them. So I assumed they closed it on their own. But the stroke service did that also routinely, and we closed most of them. And there were complications, no question. There were a couple of carotid dissections because, the patient comes in, everybody's running around, it's busy, and then they do, at that time, ultrasound was used sometimes, not always. Do you use ultrasound every time? But I'm talking for transcarotid. Yeah. Yes.
Great, thank you, Amal. I have a quick question before we move on. For Amal and then for Rob. Currently, most people will shy away doing the direct carotid puncture for post-TNK or TPA patients. What is your experience for doing that? Anybody, feel comfortable after systemic TNK thrombolysis? We do femoral puncture all the time, right? That's the standard protocol. But what about the carotid? What is your experience?
You want to?
Well, I mean, I think you're definitely much more nervous because a neck hematoma is a lot worse. But I think you have to do it open and just be meticulous and close it. It's really a small hole, so the carotid should be okay. But I think we're definitely nervous after TNK.
Yeah, I mean, I think that's a good reason to do a cut down preemptively. I mean, you may be able to get away with it after the fact, repairing the artery after a percutaneous puncture, but it would be probably safer to do a preemptive cut down on.
So you're comfortable doing the carotid cut down post TNK?
Yeah, you can. I mean,
You can do it. You just have to be very meticulous about
yeah.
about the hemostasis. But I wouldn't say we're comfortable. You have to
Push
say,
yourself, you can't get up there and then.
but if you have to save brain, then brain's more important than dealing with the little excess bleeding.
Then you have a comment?
Hi, Daniel from Neurosurgery. In fact, it's not a question, it's a comment. First, I loved your talk. Congratulations, super good. Second, I feel that what makes us so strong, it's that collaboration, the working together, having one common goal, that safety, efficacy for the patients. I think your team is super available always. We have good news. Hopefully, our biplane room in Gelman 4 will soon be ready. And I feel this is an opportunity to have even a closer collaboration. I'm very looking forward. Thank you.
Yeah, I mean, I think that's going to be key. The hospitals in the planning stages of placing a full biplane hybrid room in the operating room, which allows us a much closer collaborative effort. No question.